When evaluating hair loss, the first crucial step is to distinguish between non-scarring and scarring alopecia. Any signs like erythema, scale, a loss of follicular openings, shiny skin, or distinct patches of complete hair loss are red flags. These findings should prompt an urgent referral to a dermatologist, as they may indicate a scarring process that can cause permanent hair loss. Understanding the classic patterns of common hair loss conditions is key to diagnosis. For instance, female pattern hair loss often presents in a very specific way. The part in the middle of the scalp slowly widens over time, creating what's often described as a Christmas tree shape when viewed from above. It's important to note that the front hairline usually stays put. This contrasts sharply with chronic telogen effluvium, where the scalp might still look relatively full, but the patient experiences a dramatic increase in shedding. This shedding is most noticeable in the shower or on a hairbrush, and it can be so significant that patients sometimes bring in a bag of hair to show just how much they're losing. A third common pattern belongs to alopecia areata, which causes clearly defined round bald spots. A telltale sign here is the presence of short, broken hairs around the edges that look like little exclamation point hairs, and sometimes patients may also have small dents in their fingernails. One of the most frequent clinical challenges is telling the difference between female pattern hair loss and chronic telogen effluvium, especially since the two conditions can exist at the same time. The core distinction lies in the mechanism. Female pattern hair loss is a diagnosis of hair thinning due to the miniaturization of hair follicles, while chronic telogen effluvium is a diagnosis of excessive shedding. This shedding is typically diffuse across the entire scalp and is often triggered by a major physiologic or emotional stressor that occurred 2 to 3 months prior. Common triggers include a major illness, surgery, childbirth, or significant weight loss. A simple in-office maneuver, the hair pull test, is usually positive in these cases, meaning more than 10% of the grasped hairs come out easily. When female pattern hair loss is suspected, it's vital to check for any signs of hyperandrogenism, such as hirsutism, cystic acne, or irregular menses, and to rule out common metabolic issues. A thorough lab workup is essential and should include total and free testosterone, DHES, a CBC, ferritin, TSH, and vitamin D. This helps build a complete clinical picture and guide the most effective treatment strategy. The cornerstone of therapy for female pattern hair loss is minoxidil. It can be used as a 5% foam applied daily or as a 1 milligram oral pill taken daily. Minoxidil works by prolonging the anagen or growth phase of the hair cycle and improving blood flow to the follicles. It's crucial to counsel patients that an initial period of shedding is common in the first 1 to 2 months of treatment. This shedding can be alarming, but it's actually a sign that the medication is working. True regrowth is a slow process, taking 6 to 12 months to become noticeable, and treatment is generally considered long-term. A common side effect to be aware of is hypertrichosis, which is unwanted hair growth on other parts of the face and body. If the lab work reveals hyperandrogenism, then second-line options like spironolactone or finasteride can be contraindicated. However, it's incredibly important to remember that finasteride is strictly contraindicated in pregnancy. For any patient taking systemic antiandrogens or oral minoxidil, you must ensure they are on reliable contraception. Beyond medical treatments, holistic patient counseling plays a significant role in managing hair loss. It's helpful to advise patients to avoid tight hairstyles, chemical relaxers, excessive heat, and rough brushing, as these can all worsen traction or breakage. It's also important to normalize the use of camouflage strategies while waiting for medical therapy to take effect. These can include things like hair fibers, powders, shifting the part, or even hair pieces. Finally, we must always recognize that female hair loss is strongly associated with anxiety, depression, and body image distress. It's essential to explicitly validate these feelings and consider brief screening for mood or anxiety disorders when it seems appropriate. A dermatology referral should always be considered for atypical patterns, rapid progression of hair loss, or if the patient experiences pain or itching. A referral is also warranted for any clear scarring features, focal patches, or a simple failure to standard therapy. In these cases, a scalp biopsy may be necessary to reach a definitive diagnosis.